Hello and welcome. Thank you for your time, Professor Trubitsky, to do this interview, which I think will be on immense importance for patients to understand the research that you are doing. And we will talk about your PREDICT paper, Patterns of Acute Decompensation in Cirrhosis, which you and authors wrote and published in Journal of Hepatology. So, Professor Trubitsky, you are the principal investigator of the PREDICT study, a prospective large-scale observational investigation performed by European Association for the Study of the Liver, or EASL, Chronic Liver Failure, CLIF Consortium, and 136 investigators from 47 centers and institutions in 14 European countries. Wow! You and the PREDICT Consortium analyzed samples and clinical data from 1,071 patients showing acute decompensation of cirrhosis in order to predict acute and chronic liver failure, or ACLF, a syndrome characterized by organ failure and high-grade systemic inflammation and associated with very high 28-day mortality rate. What were your main findings?
Thank you very much, Marco, for this kind invitation. I'm very happy here to be together with ELPA and to have this interview on our first PREDICT study. Indeed, the PREDICT study aimed to characterize more in detail the phase just before development of acute and chronic liver failure, as you outlined very nicely. With a very high mortality, this is a dramatic disease. And indeed, in this first paper of the PREDICT study, we could distinguish three different groups of patients that had different courses of disease. We had the first patient group with the highest mortality who developed ACLF, acute and chronic liver failure, within 90 days. And we had the largest group of patients, which were almost half of the patients' population that we investigated, with a stable decompensated cirrhosis, and these patients did not develop any events within the 90 days of their follow-up within the study. So indeed, apart from these three different groups that we could distinguish in this observational study, we could also highlight two mechanisms which were mainly responsible for the acute decompensation and further outcome of these patients. As you highlighted already, the systemic inflammation, which is closely related to the development of acute and chronic liver failure. So we could confirm that the patients with the pre-ACLF group, they had also very high systemic inflammation, the highest, and these patients with a higher systemic inflammation, they developed also acute and chronic liver failure. But also, there were patients in the unstable decompensated cirrhosis. The main mechanism were complications of portal hypertension. So portal hypertension is another extremely important pathomechanism in the development of complications and decompensation in patients with decompensated cirrhosis. So having these two different pathomechanisms, we could also highlight the different courses of disease, role of infections, and many other granular data in these patients, which we followed very closely for 90 days.
What are the most striking differences between the groups, and what does this mean for patients? Is there any way how patients can tell themselves to which group they belong to?
So since this is an observational study, we are also limited by the nature of this study. We observed first this evolution of the disease, the course of disease, and then we decided which are the groups of patients that are different to each other, with different outcome and with different pattern of disease. We have two things which are probably very helpful for the patients. The one is systemic inflammation, really simple markers of systemic inflammation like CRP, so C-reactive protein, or white blood count, so leukocytes. So these are really things that in the routine practice, many physicians do. And indeed, if the patients have high levels of white blood count or CRP, we should be aware that they may be patients with pre-ACLF. So these patients need more care. On the other side, there are patients with signs of severe portal hypertension, like or huge development of ascites, repetitive paracentesis, esophageal bleeding, and so on, varices, and so on. So these are signs that characterizes more the patients in the second group with the unstable decompensated cirrhosis. And therefore, there are some surrogates which we can distinguish between the groups already at inclusion. Nevertheless, for a very nice prediction of the groups, we need further data and further studies.
In regards to everything that you said, if I understand this correctly, patients can be divided into different groups, and with that, you have different patient management.
Yes, correct. So the management is not yet shaped to these groups. So these are really novel findings. And this first needs to be accepted by the community. And then we need to develop strategies to manage the different patients groups. Nevertheless, as I said before, so the pre-ACLF group, it's mainly systemic inflammation. Bacterial infections play an important role. In the unstable decompensated cirrhosis, it's mainly portal hypertension. So we should use the strategies to decrease portal hypertension, to treat complications of portal hypertension in these patients, for example, non-selective beta blockers, TIPS, and so on. So this would be our strategy in this patients group in order to decrease the risk of development of further complications and death. And in the patients with stable decompensated cirrhosis, we can just observe them as now because they have very low mortality rate and also very low risk of developing further decompensations and die in 1 year. So we can shape our treatment strategies according to these groups. Nevertheless, we need first to predict the groups in order to shape the management. The score which we developed for the PREDICT study for this first paper, nevertheless, was a little bit better, but not extremely better to predict development of ACLF in the patients with acutely decompensated cirrhosis.
You said something about the beta blockers and you said something about TIPS. Can you just explain a little bit more what beta blockers means for the patient and what TIPS means for the patient?
Yes, of course. So these are strategies to treat portal hypertension. Beta blockers are used especially for patients who have varices needing treatment. These are non-selective beta blockers. You can prescribe this and you can take this. It's just a drug, which is also usually well tolerated. It has side effects, as all drugs have, but also we know that the non-selective beta blockers may prevent variceal bleeding. On the other side, TIPS has been shown, especially recently. Also, there were 2 papers in Journal of Hepatology showing very clearly that patients with high risk of mortality, patients with acute and chronic liver failure, and acute variceal bleeding, either in a refractory bleeding setting or in a severe bleeding setting, they benefit very much from an introduction of a TIPS. And also what we observed in the PREDICT study, there were many patients who received TIPS from the acutely decompensated patients due to complications of portal hypertension. And these patients developed readmissions and an unstable disease. And this was a surrogate to say that the one mechanism, or the most important mechanism in the group of patients with unstable decompensated cirrhosis is portal hypertension. This is what we knew from years, but nevertheless, it is the first time that we specifically identify this group of patients within the acutely decompensated cirrhosis.
So you mentioned also TIPS as a way of treating hypertension. Can you just explain a little more what TIPS means?
Yes, TIPS is a minimal invasive procedure which is performed usually in cooperation between the interventional radiologist and hepatologist, where we create a shunt in the liver between the portal vein and the hepatic vein without operation. So this is just a catheter procedure. And we put a stent between these 2 vessels, and thereby we decompress the portal vein and we decrease portal hypertension. This is very useful, especially in patients with complications of portal hypertension. And there are several studies and many studies and more than 20 years of experience or 30 years of experience showing that TIPS in specific settings improves survival of patients. So TIPS is very useful to treat portal hypertension and complications of portal hypertension.
Is it possible to predict the course of disease? And if not, what do you need to predict it?
Yes, we tried to do this in our PREDICT study, as I said in the beginning, since using the routine markers and clinical features of the patients, we were able to improve very little the scores which are already available for the patients with acutely decompensated cirrhosis, which is the CLIF-C-AD score. So the new score which we constructed, the CLIF-C ACLF development score, performed a little bit better. Nevertheless, not sufficiently to say that we really can do it with a high sensitivity and specificity, distinguishing the three groups from each other. So in the PREDICT study, we were anticipating these problems. Therefore, we collected many biomaterial of the patients included in the PREDICT study. And indeed, in few other projects, we are very much into the prediction, into the discovery of new biomarkers to predict outcome of disease and to predict also these three prognostic groups of patients with such a distinct course of disease. One of the projects, which I am the coordinator of, is funded by the European Commission, and it's a Horizon 2020 project called Microbe Predict. Here we are using the microbiome markers, not only of the stool, but also in the other samples, to see whether we can predict, on the one side, the development of disease, development of ACLF. On the other side, probably to distinguish between the three groups, pre-ACLF group, unstable decompensated cirrhosis, and stable decompensated cirrhosis patients, because this will change crucially the management of the patients, as we discussed it before, and also to see some responses to drugs, whether we can use the drug safely or not in these patients, and whether there would be an effective treatment of these patients. So we hope that with this huge project, because this is a project with a budget of 15 million, there are 21 institutions in this project, and also ELPA is one of the partners in this big project. And we hope that in the near future, we can predict the different courses of disease already at admission in these patients.
I think that would be a great result and a great benefit for the patients. If you can manage to predict the course of the disease, in this in-depth characterization of patients and allocations to different groups, does this help to make more personalized and more effective treatment choice?
This is a great question, and indeed, we also were thinking of this, and there is another Horizon 2020 project. The coordinator is the European Foundation for the Study of Chronic Liver Failure, so EFCLIF, and the PI is Pierre-Emmanuel Ratou from Paris, and we are working exactly on this combination of drugs which may benefit the patients to prevent acute and chronic liver failure. The Decision Project is a project funded by the European Commission with a budget of 6 million euro, and will analyze exactly the combinations using multi-omics techniques to see which are the patients or which are the treatments and for which patients these treatments are more effective, and the combination of those treatments which are already available. Because we're doing a lot in our patients so far, and the patients know it very well, because we're trying this and we're trying that. The question is whether there is a fixed combination or whether there are patients which will respond better than others, and so on. So this is the goal of our project, to shape the treatments and to make it more personalized for our patients. And I believe that also through this first PREDICT study, demonstrating a very different clinical courses of disease, we hope to find combinations of drugs for each of these groups in order to prevent further decompensation, acute and chronic liver failure, and mortality in these patients.
Thank you very much, Professor Trebitska. In this interview, we covered not only your paper, you talked about also your research in Horizon 2020 projects, MicroPredict, and also in the project's Decision. So for the end, would you say something that would be important for patients to know, or general regarding the high-level research you are involved in?
Thank you very much for this interview. Also, my final words would be that this paper is a milestone for the clinical research in cirrhosis. And it is a milestone not only because we have characterized these three different courses of disease, which will be further characterized or further initiate research in the future, but also because there were so many patients and so many family of patients involved, which I am very grateful to. This was the first people who our gratitude should go to for the research, for their willingness to participate in this study. I am also grateful to the 136 investigators and more other helpers which contributed to the study from 47 different centers across Europe. and also especially to the young investigators, which will take this research from here and will bring it to the next generations to predict exactly these different outcomes and also to shape the management of the patients and to treat the patients accordingly to improve the burden of disease or to decrease the burden of disease. So indeed, it takes more than 1 or 2 generations to develop this, to come here. And this is also very nicely demonstrated in our paper because we have also very experienced researchers which are already emeritus in our group leading us, and people from the middle age and also very young scientists which have carried the burden of this study and which we hope that will keep our hopes in the future. Yeah.
So thank you very much again. So I think it's very good to know that high-level research is not a production of one person, but a bunch of people who are just pushing the boundaries of everything that is possible and improving the reality for liver patients. And thank you very much for your time, availability, and I'm sure we will hear more about you, and we will definitely invite you to another interview when you have more results and outcomes. Thank you very much.
Thank you very much again.